So now what we want to do in the next panel and in the second one that will follow after a short coffee where we'll do in the middle is to learn from local initiative project practices that in a way or another are addressing some of these aspects that have been already mentioned regarding attracting healthcare workforce, supporting them, or also how to combine different mobile healthcare telemedicine, different methodologies that might complement the work and might support the World Health Force. So without further ado, because the important thing is to really learn from our inspiring speakers, I will welcome Dr. Stefan Mandic-Rajcevic from the Faculty of Medicine of the University of Belgrade. This is also the Secretary General of International Association for Rural Health and Medicine, and part of the HEAD project that Christoph mentioned earlier this morning that was funded by DG Santi. And please, Stefan, the floor is yours.
Thank you very much. And can you just confirm to me that you can see my presentation in full screen, that everything is okay?
Yes, we do. That's perfect.
Okay,
thanks.
Perfect. So thank you very much for this opportunity to talk to you today, and also to hear a lot of interesting presentations. I think it's really a big learning event what we're doing right now. I will talk about the medical desert as seen by the HEAD project, and how this can improve attraction and recruitment of health workers in rural areas. So I will talk a little bit about the HEAD project and methods, but I will not spend a lot of time. So there will be probably some open questions. Feel free to write them in the chat, or write directly to me, or ask them later, whatever you prefer, or look at our website that I will share also, and it's in the program. I will talk about the dimensions of medical desertification, how we have visually represented medical deserts, what are the needs of health workers in medical deserts, and some policy options that we found. So as you know, the HEAD project was part of the third EU health program. Our idea was to investigate and define and validate medical deserts, and our definition is, and also I agree that not only medical deserts is not really a happy name, and also I think a lot of areas that we worked with are not happy to be called medical deserts. So I kind of can echo what John said. It's maybe not the perfect way to call these areas, but this is a medical desert is an endpoint of a process which is called medical desertification, and implies continuous and increasing inability of a given population to access health services in a timely and contextually relevant manner. I want to show just how visually we have presented data for Serbia, thinking about the number of general practitioners per 10,000 of adjusted population according to their needs based on the age of the population, how we have used the number of pediatricians per 100,000 populations in different, first map is about municipalities. The second map is about districts in Serbia, and how these the number of pediatricians vary between different districts of Serbia, and finally the number of gynecologists per 100,000 of female population. Again, how this number varies between the districts in Serbia. These are all three kinds of medical doctors that exist at the primary healthcare centers, the way that the Serbian healthcare is organized, and it's also we are quite proud that also Andrija Štampar, who was the Yugoslavian representative, was mentioned before, and we are proud of these roots of to healthcare to a wide range of people. Unfortunately, that is changing, as we will see. Then we try to do a kind of a graphical representation of medical desertification in one of the districts that participated very actively in our work in Serbia, where, for example, we have points for availability of general practice, pediatrics for different age groups, because this is how this data is reported in Serbia. Then performance, meaning the number of exams they have to do, thinking about the more examinations or physical examinations medical doctor has to do. It means that they are more stressed, burned out, and exposed to higher work burden. And finally, from different surveys, the unmet needs. And some of the unmet needs were due to the pandemic, as our project was happening during the pandemic, but also because of the distance, personal time, waiting time, and financial resources, which are all indicators of medical desertification. So what was interesting about our approach is this consensus building that has the idea of obtaining some kind of a general agreement that we can later use to direct our activities. Of course, it's not necessary or expected that all the stakeholders will agree with each other in every respect. And we focused on a wide range of locally developed solutions. And the consensus building allowed us for a better decision making because we involved different stakeholders. When we discussed this at the local level, our stakeholders were local government representatives, local health workforce, and the local patient representatives, or just patients, also patient organizations, but we tried to hear from all three sides when we did the consensus building. Through the consensus building, we arrived at some policy options, and I will first discuss some policy options for Serbia, and then some general level policy options for the European Union. So there are some government level policy options where it's important to implement a regulatory act to combat the process of medical desertifications. And of course, the first point is to build a supply of competent and motivated health workers in medical deserts, which would result in equal access to healthcare. And how can this be done? And you will see this repeated a few more times through my slides. This will be done through subsidies and incentives for health workers, meaning some kind of benefits and higher salaries for employment, and dual practice in medical deserts. More jobs opened in medical deserts for health workers who are board certified, and a kind of mandatory health workers practice in medical deserts during the fellowship period, internship and residency programs. So something that they can do, and they can try working in medical deserts and see how this works for them. In the other hand, the modernization of healthcare delivery in medical deserts, promoting higher efficiency in healthcare delivery, enabling mobile healthcare practices. And I saw in the program that we will listen also about this. So this is really great. So mobile doctors and diagnostics, mobile nurses and home care, mobile labs, mobile pharmacies, mobile therapy, and surgical clinics. And building health worker competency and insurance, which would also result in improving healthcare effectiveness. So trying to find more places where health workers can do training closer to medical deserts, developing training curricula for rural health, creating health worker professional networks for e-consultations and e-teamwork, and coaching health workers for telemedicine, being able to apply these new technologies in medical deserts. What we were interested in is to hear what the solutions the local stakeholders found for medical deserts. And some of these solutions were directed at the stock and skill mix of health workers, and some were directed at the supporting working and living environment of health workers. So let's first see what was identified as really important for the health workers. first to identify the health workforce needs, to provide up-to-date evidence of the health needs of the population in practical terms, even discussing this with the population in areas identified as potential medical deserts. We noticed that they feel they have specific healthcare workers which are maybe not a priority for them, but on the other hand, they lack healthcare workers which would be important for them. It's important to have local information and monitoring of the health workforce flows, to participate in the health workforce planning and development so that you have a local voice in health workforce planning and development, to propose revised staffing standards for general practitioners and nurses, recruit more healthcare workers, participate in organization of field work of mobile clinics, and create various types of incentive packages. Of course, there are the other part regarding support in working in medical deserts. It would be investing in digital solutions for professional consultations via tablets, mobile phones, digital solutions for patient consultations. Investing in more medical trainings in schools closer to the priority areas. Increasing the moral and image of local health workers, and developing local policies for the migration and mobility of health workers. And I want to finalize. Yes, I will finish here. I want to just give some final remarks on what was identified as the priorities for the health workers in the medical desert, and that is to increase the earnings and the number of employees in medical desert, because not only that when you lose healthcare practitioners in medical desert, the ones that remain they have more burden, and then they're more likely to also leave, but also to increase their earnings according to the job they're doing, to create benefit packages for healthcare professionals for employment in medical deserts, meaning incentives and support for healthcare workers, regarding also their living and working environment, and in some countries also allowing good access to housing, modern, well-equipped buildings with the right utilities, Wi-Fi for the GP practice and also for living, to adapt always the profile structure to the population needs, and to strengthen home treatment and care services for the aging rural population. And why it's important for health professionals, associations, and citizens to participate in this, because they can really provide input for the policy solutions. They can advocate for the right to health for all, and they create the future awareness of the needs of most vulnerable populations, including those populations in medical desert. And I thank you very much for your attention, and I'm open to questions, comments, also in the chat, whatever you prefer. Thank you very much.
Thanks a lot, Stefan, for this presentation about medical certification with special remarks about the workforce. There is a debate going on in the chat regarding the investment, and how some studies shows that investments €1 in the health service increase the gross domestic product. We will have a specific working group on this, so do not hesitate to keep all the things that you want to discuss, because there will be later today a full time devoted to do that. But now I want to move to the next speaker, to Vlad Berbecar, the founder of CARAVANA MEDICI. It's actually linked with some of recommendations that have been already mentioned. We mentioned how to enable mobile clinics, as well as something that can leverage the access to health services. And you, Vlad, have been delivering these mobile multidisciplinary health services with your Doctors Caravan Association. So please, Vlad, the floor is yours for 10 minutes, please, no more. And yes, let us know.
Thank you, Gracìa. Thanks for the invitation to this event. Can you see the screen, the presentation?
Yes, we do.
Okay, so I'm going to shortly describe one of the projects that started in Romania in 2014. We started this project as an association, in order to improve healthcare access in rural and remote areas. So the main idea was for the Doctors Caravan Association to bring a team of doctors from the from the big hospitals to the countryside to provide basic and advanced medical care and perform screening and diagnostic tests, raise awareness, educate the rural population on the importance of prevention and a healthy lifestyle. So, of course, why we did this, because there is a huge lack of medical resources in the rural countryside. In Romania, almost half of the population is located in the rural setting, and almost 90% of the physicians and medical units, hospitals, ambulatory services are located in the urban setting. So how did we start this? We teamed up with some of my colleagues, and we created a multidisciplinary team of doctors. We also had help from medical residents and students, medical students, and we literally went to the countryside and started offering free medical services. Now, the setting was pretty advanced, so we offered medical services, something similar to what you can receive in an outpatient setting in a hospital. We provided clinical examinations, we do blood tests, we do EKGs, abdominal and cardiac ultrasounds, and we provide recommendations, treatment or for further investigations when necessary. Of course, we did these activities during the weekend. At least that's how we started. Now we depending on our time, of course, we try to do them as often as we can. Sometimes we use mobile health units, but sometimes we use the resources that are locally available. So we set up a space in the school or the town hall that we and sort of create something like a hospital circuit where patients enter and go through different examination rooms, blood tests, EKGs, of specialist consultations. And we can evaluate approximately 100 patients a day with a team of, I don't know, maybe 10 physicians and 10 medical students and residents. We have also tried to focus our caravans on different pathologies. So we have caravans, pediatric caravans, or caravans dedicated for the female health, where we do pap smears and memory ultrasounds. So the overall activities that we do is evaluate the health status of the population, assess and manage risks for the most prevalent diseases, perform advanced medical screening and diagnostic tests, define individual treatment plans, consider appropriate further investigations when needed. And we have this is where we have a really good collaboration with the GP, with the family doctor. That is an important piece in everything that we do. Promote prevention medicine and try to give basic medical education. And we also try to, after the caravan ends, we also try to monitor the treatment adherence and the health status by a long-term follow-up. And of course, we try to do reports and statistical analysis on our findings. So the project was a real success. It started with a few caravans and has turned in 9 years into more than 200 caravans, with over 30,000 patients being evaluated, been given free medical services. We have set up multiple divisions throughout Romania, and we have gathered hundreds of volunteers. We also expanded our infrastructure and increased our capabilities with telemedicine and an e-health platform, which we use to assess the patient, and afterwards we try to follow up and provide medical support through telemedicine. I need to mention that this project is, or at least it started as an NGO, and all the medical services that we have provided are free, or initially that's how it started. Now we have different projects in collaboration with local resources, where some of these events are funded either by private funders or through local administrative groups. And we are now working on an integrated model to provide these services through the National Health Insurance House. We're trying to do this because we have had a really good success with the project, that we have actually created a legal framework for this type of approach, for this type of medical services. We have created the Mobile Healthcare Act, which passed in 2022 in Romania, and it has become the official law for providing medical mobile services. So in our point of view, this type of medical services is really useful to a large proportion of the rural population. This concept where the medical system comes to the patient and other way around improves access to patients' health care. We have had a really good success with this project, and it is ongoing, and it increases from year to year. This year we have organized over 40 caravans and examined almost 10,000 patients. The mobile healthcare model that we are using can be a solution for people living in rural and remote areas, because it is an efficient way to provide primary prevention and health services. Thank you for your attention, and if there are any questions, you can write them in the chat.
Thanks a lot, Vlad, for this presentation, and congrats for this success in passing the Mobile Healthcare Act. I think it's a remarkable achievement that you have managed to formalize, thanks to the work that you and the colleagues do in the Caravan community, to have these mobile services institutionalized. I think there are some comments and also questions regarding immunization in the caravans that you can perhaps address in the chat, and we will have the opportunity to continue chatting with you later in the breakouts. So thanks again a lot, Vlad. And now, last but not least, I would like to welcome the third speaker for this session before we go to have a short coffee break. And this is Cristina Gracìa from the Aragon Institute of Health Science, that is going to present the ROSIA project, that is integrated support for remote rehabilitation for isolated and rural areas through the use of technology as well. So good morning, Cristina. I think you will be sharing your screen as well.
Yes, I'm trying to, and thank you, Patricia. I don't know if you see.
Yes, we see it. Please, the floor is yours.
Presentation mode, or is
yes,
it okay?
In presentation mode.
Okay. So thank you for inviting us here and letting us present the ROSIA project, and especially learn from other initiatives and from this community that is so great, so huge, that we didn't really know. So let me, because I have a problem here. So I try to be very brief because, oops, I'm having some issues here. Yes. Okay. So very quickly, what is ROSIA? ROSIA is a project funded by the European Commission through the Horizon 2020 program. It is a pre-commercial procurement for digital health and care solutions that started in 2021, and then it will finish in 2025. The goal of ROSIA is to design rehabilitation services for remote rural areas, taking advantage of new technologies to integrate social and health services with the community resources. So the final aim is that telerehabilitation services can be prescribed and supervised by specialists in the healthcare facilities. Yes, so, well, it's clear that patients and healthcare providers in rural and isolated areas could benefit from telerehabilitation, and new technologies and apps already exist, but the problem is that there is no entry door for these apps and devices into the healthcare system at the moment. So what ROSIA is willing to unlock the telerehabilitation market by purchasing the development of a technological innovation ecosystem, and then integrating this into the healthcare system. The health services will be able to provide telerehabilitation, self-management, and self-care at home at scale in all Europe. Very briefly, ROSIA is a pre-commercial procurement project. It's a tool to stimulate innovation because it lets the public sector to steer the development of new solutions directly towards its needs. So public procurers buy research and innovation from competing suppliers, compare the alternative solutions, and identify the best value for money ones. It is divided in phases, with competing contractors being reduced after each phase. And the idea is that when the project ends, the solution, the final solution, can be purchased by the public health system through a commercial procurement process. In ROSIA, 5 entities were awarded in the first phase for the design of the solution. Now we are in the second phase of prototype development, and next year we'll have the next phase, that is pilot testing. ROSIA involves 12 partners across 5 countries. It's coordinated by the Aragon Institute of Health Science. And in addition to the public procurers involved, there are several knowledge partners that help with their expertise in the design, the preparation, and the implementation of the project. The 3 buyers, the 3 procurers that are involved in this project are the Regional Health Service of Aragon in Spain, the Coimbra University and Hospital Center in Portugal, and the National Rehabilitation Center in Ireland. And why ROSIA? So we can agree that the public health system in Europe needs to facilitate the rehabilitation of patients, especially those that have problems to travel to the healthcare centers, by using the telerehabilitation services under clinician supervision. And there's also a need to extend the rehabilitation period for those patients who could benefit from it by developing self-management and self-care services. And at the moment, there is no public healthcare system that deploys self-management rehabilitation in a large scale. And this is due to a lack of coordination, lack of resources, what we don't know. Oh, sorry. Lack of follow-up of the patients, geographical dispersion of patients, and fragmentation of care models and diversity of communication and technology systems. And how is ROSIA trying to solve this? Well, allowing new technological solutions to enter the telerehabilitation market, facilitating self-management, implementing a flexible model for personalized integrated care, enhancing the role of the community and empowering patients, generating evidence of the value of the telerehabilitation model, creating an open platform, and generating a business model for the long-term sustainability of this model. Here we have the core aspects of the ROSIA innovation ecosystem. The whole ecosystem is framed in a value-based model with 3 building blocks: motivation and empowerment of patients and carers, integrated care, and telerehabilitation. And this model ecosystem has 3 different layers. That's the catalog, the developers layer, and the open platform. We'd like to mention that the participation of the end users is essential in the design and in the testing of these solutions. And in the preparation stage of the project, the ROSIA partners worked on identifying the users' needs and requirements with interviews, workshops, questionnaires involving healthcare professionals, patients. And the idea was to understand how the current rehabilitation pathway is, learn how patients experience their pathological conditions and how they experience the rehabilitation process, and find out the main shortcomings and their needs also. And this research has been a guiding point for the companies that are working now on the solutions. Now in the current phase of prototyping, the 3 contractors that are working have made demonstrations to a group of patients and healthcare staff from a role-playing perspective, with videos, with questionnaires, and they are gathering their feedback to improve their solutions. And in the next phase that starts next year, the 2 selected solutions in phase 3 will be tested in 2 locations of each of the 3 procurers, in Spain, in Ireland, and in Portugal. And just a final remark, we would like to mention that if the ROSIA piloting has good results and then the healthcare providers decide that it's interesting to implement it in the future and it can be purchased by the system, there are 2 basic conditions that will define the final success or not, and the sustainability of the system. And they seem obvious but are crucial, and these are a good access to the internet and basic digital skills of potential end users, especially in rural areas, and of course a strong workforce of motivated healthcare professionals in the rural areas. And that was my last slide. Thank you very much.
Thanks a lot, Cristina, and good luck with finalizing this pilot, this important tool. We are speaking about the solutions that will be delivered as part of this rehabilitation telemedicine. And there was the comments in the chat that this is a tool to complement what the doctors are doing to deliver and to ensure the health access. I think it's very important also to mention what you said about involving the end users and to take into account perhaps the digital divide that it might prevent some people from using, and therefore to take them into account when the solution is designed. And I think is what you are doing in ROSIA. So we're going to continue with from listening to some local projects, initiatives, and also European projects that have been addressing in a way or another different aspect that we've mentioned regarding access to health services in rural areas. And the first speaker that is going to open this second panel is Giovanni Baglio from the Italian National Agency for Regional Health and Services from the OASIS project, which is also one of those medical deserts projects that was mentioned by DG Sante earlier today. So good morning, Giovanni.
Good morning, Patricia.
How are you doing? Hi, Giovanni.
Everyone, thank you very much for having me today.
So you're going to continue with the medical deserts, but a different perspective.
Yes.
So please, Giovanni,
Measuring.
The floor is yours.
So I'll try to share my. Okay, can you see my presentation full screen?
Yes, perfect.
Okay.
Thanks, Giovanni.
Okay. So I'd like to share with you some information about OASIS, which is a project on medical deserts in Europe, co-founded by the European Commission. It started in March 2021 and it's currently approaching its end in February 2024. The project aims at defining and sharing methodologies and knowledge on how to measure medical deserts in order to develop common policies and strategies to successfully deal with the challenges posed by the underserved areas in European countries. Italy is coordinating the consortium, which involves 6 other European states: France, Cyprus, Romania and Moldova, Hungary, and Finland. With particular reference to Italy, the issue of medical deserts assumes an extraordinary importance at this specific moment when we are rethinking our national healthcare system after the pandemic, also thanks to the financial resources of the Recovery Fund. And for this reason, in the case of Italy, we have tried to adopt a broader definition of the concept of medical desert, which refers to any situation in which criticalities arise in the meeting of health needs, demand, and supply of healthcare. It includes not only the simple lack of health workforce in a geographical area, but also those situations where services have a poor quality or where specific subgroups of the population are not able to have access to healthcare. Starting from the WHO framework, we summarized the relevant aspects in the form of 3 key questions concerning the provision of services in a specific area. The first question to be asked is, are there services? That is, are there enough healthcare facilities, hospitals, rehabilitation centers, and are there enough health professionals? This is a dimension of availability. The second question is, if there are services, if so, do they work? This is a dimension of quality. In fact, having services that do not work properly is evidently a form of medical desert. And the third question is, the services that are there and that work for everyone in the same way? We know that specific subgroups of the population are often unable to have access to health programs or services due to geographical distance or to other factors such as linguistic, cultural, socioeconomic, and organizational barriers to healthcare utilization. And in order to make such a broad definition usable for the analysis, a specific matrix has been developed, which shows in the columns the 3 dimensions described above: availability, quality, and accessibility. And in the rows, the 2 ways of looking at the supply from the point of view of the characteristics of supply to occur, and from the point of view of the provision of services in the face of the health needs expressed by a resident population. And the matrix highlights 6 areas which should be seen in a synoptic view. Availability is declined in terms of presence and coverage of the population. Quality is declined in terms of performance of services and protection ensured to the resident population. And accessibility is declined in terms of usability of services and equity in healthcare. An example of indicators of presence, represented in the form of a map, concerns general practitioners, and in particular, the proportion of professionals aged more than 65 years. As you can see, general practitioners in the northern part of Italy are younger than in the south. But, on the other hand, when you consider population coverage, you can see that in the north there are fewer general practitioners than in the south. As they say, if Athens cries, Sparta doesn't laugh. This is a representation of the composite score referred to the dimension of availability of healthcare professionals, not only general practitioners, but also other medical specialists. With the main critical areas in Italy for this dimension. And we are also preparing composite indicators for quality and accessibility as well. In conclusion, what are the perspectives for the future? First of all, the activities we are carrying out in Italy within the project become paramount in the light of the Italian recovery plan, whose impact deserves to be carefully evaluated and monitored over time. Another important point for us is the issue of health system financing. Actually, in Italy, the internal debate concerns the possibility of using healthcare deprivation measures as a criterion to allocate health funds among regions and among local health units, linking the delivery of funds to the achievement of strategic and measurable objectives. Finally, the challenge we face in the future is to define a common set of measures that can be calculated by all European countries, applicable in different contexts and sustainable both at national and local level, in order to develop common policies and intervention plans. Thank you very much for your attention.
Thank you very much, Giovanni, for the presentation of this matrix for the availability, quality, accessibility. You all mentioned at the end of your presentation this goal of common set of measures, but all EU countries, and actually that was resonating with a common questions that one of the participants, Veronica, said, that could this matrix be used to start to develop rural health indicators for the EU? So perhaps you will be in the breakouts together. There's can be part of the discussion, but you might also want to exchange with Veronica via the chat.
Yes,
and
okay.
Thanks again to Giovanni. Thanks a lot. Now I would like to welcome Alban Davesne. You are already putting up your presentation for an intense 2-year research project regarding cross-border services, and you, Alban, are going to touch upon specifically something that I think it's very important, which is the access to the maternity health in rural border regions. So this part of the comprehensive study that you've been doing in the Harbour project. So hi, Alban.
Hi.
Welcome. And
yeah, thank you so much. Do you see my presentation?
Yes.
In full screen? Yes, thank you.
We do. Thanks.
So I'm very glad to be here. It's a great opportunity to present some of my preliminary findings for this project called Harbour that I'm currently doing. And what I find really interesting in this context is that I will talk about cross-border healthcare, which is, of course, a broader and important topic, especially for the EU. But I will do so in connecting that issue to the one that is actually at stake today, is the rural access to medical services. And what is interesting when you look at border regions is that access to cross-border healthcare in border regions is actually the oldest type of mobility and the most common in Europe. And it has been somehow less investigated, and especially in a wider European context. Patient mobility, patients seeking healthcare by flying to other countries, for instance, dental care in Hungary or things like that, have gained way more public interest than what is happening in border rural regions. And And cross-border care in that context is often seen as more self-evident, less problematic, maybe more niche, so that it doesn't gain as much interest. And more specifically, I will talk about border residents giving birth on the other side of a border, which is an interesting phenomenon, which clearly highlights the key component of what we are discussing today is the importance of proximity and the sheer distance to care that could be a major issue to people. It's of course only one aspect of my research, but I will focus on that today. So this is the broader overview of my project, and I won't go into details, but the idea is to compare the border interactions in specific rural border areas, and to come up with a framework in which you see those regions are integral part of a healthcare territory, and to actually investigate the challenges and the potential for cooperation in that context. My case studies are twofold. So there's the Norwegian-Swedish border and the French-Belgian border. In those two cases, I look at regions that are highly integrated in many respects, socio-economic, a lot of cross-border activities, and arguably a similar cultural and linguistic area, although Swedish and Norwegians are two distinct languages that understand each other, which is quite key in the context of healthcare. So I will just briefly show you some of the situation that is on the ground, and then I will make some more general comments about cross-border healthcare in rural areas. One key element to keep in mind is that although not all rural areas are border regions, of course, but if you look at Europe, most border regions are actually either rural, underserved in some ways, or remote. So that's kind of interesting also in that context. So let's look at the Swedish-Norwegian border. The specific region is you know, like the south of Norway. There is a little bit of Norway which is called Østfold, and it creates a geographical situation in which patients from Sweden are actually closer to a Norwegian hospital. What is really interesting in the context of cross-border cooperation is that in this case particularly, it's an old cooperation, and the legal framework for the cooperation has been set in the 60s and was more specifically defined in the 70s with a local agreement between the Swedish region and the Norwegian hospital. The scale of mobility is, you see the numbers may seem pretty low, but if you put that into context, they are, first of all, quite stable over the years. So it's a very well-established cooperation, and those numbers are slightly increasing recently. So there are 200 babies, Swedish babies, being born at the Kalnes hospital, which is the Østfold hospital. And if you look at the region, which is, if you take the border regions, pretty much 20,000 inhabitants overall, it means that in some border municipalities, such as Strömstad, it's actually more than half of the babies that are born on the other side of the border. A key element, a key contextual element for this cooperation is that the agreements and the possibility for women to give birth on the other side of the border have been defined after Swedish clinics have been closed in the border area. So it's pretty much a reaction to a problem that has been happening. And the fact that the main Swedish hospital is not only quite far, but it is often at full capacity. So the quality of care is not always the best, and there is a need for local residents to find some other ways. Another important element is that the Norwegian on the Norwegian side, there has been a new hospital being built, which has attracted also some of the Swedish residents, and the construction of this hospital has been pretty much planned or advertised as a hospital that would have cross-border reach. Although it's not, it's kind of problematic. I will come back to that. Of course, the motivations for the mobility is shorter traveling distances. Is 30 minutes from Strömstad to Østfold Hospital, and it's 1.5 hour to Trollhättan, which is the Swedish main regional hospital. There are other motivations that have been described by patients, such as a more personalized care and so on, but it's clearly not the main driver for this mobility. I will mention a few of the problems. The fact that the Norwegian hospital was built quite recently and was supposed to be to attract people from further afield, but in fact this hospital was severely built in severely under capacity. So as soon as the hospital was built, the Norwegian local authority had to stop the cooperation because the hospital was saturated and they couldn't take in Swedish patients. So the agreement was temporarily suspended in 2017. Of course, it was then suspended during the COVID pandemic, but it kind of points to a problem where limited capacity on one side of the border is one thing, but if there is limited capacity on both sides, then the cooperation kind of loses its logic. There have been some other problems with the cooperation, but it's the main one. I will come to the French and Belgian.
Yes, Alban, we need to start wrapping up, please.
Yeah. And to show you that it's actually a very similar situation that is happening with a very similar number of patients, short distance being the motivation, and more crucially, the closure of local hospital being the main driver and the reason for those cooperation. So I will quickly move to some of the general insights. The fact that these cooperations are initiated by as a coping mechanism to closures and lack of access to care. There is a dynamic of competition going on across border where hospitals on the other side could seek to attract foreign patients, but it's not the main driver. The numbers are fairly steady and fairly similar in both cases, which is interesting. And it's important to point out that in both cases, it's a one-way stream where patients go from Sweden to Norway and from France to Belgium. So it's kind of the reason for the cooperation is pretty much imbalances in the capacities on both sides of the border. Very importantly, the role of local patient groups who are actually advocating for more cooperation and for public authorities to better take into account the needs of rural border residents. And they are both advocating for more access to cross-border care, but also for better infrastructure in their own region. So they go hand in hand, I would say. There is, of course, resistance from health authorities to participate, mostly because there is this competitive dimension where you don't want to be in a weak position where you send patients across the border, and it shows the vulnerabilities and the limits of your own provision of care. But it is the reality, so you have to address that in some ways. So very
yes, you need to finish, Alban, please.
Yeah, very final word on those two models of cooperation that I've kind of uncovered. The French model and Belgian model and the Swedish and Norwegian, in one word, in France, there is a stronger realization that access to rural healthcare is a growing issue. So there are many institutions, many actors trying to solve this problem and to engage in cross-border cooperation with this specific goal of addressing this question. Whereas in the Swedish and Norwegian case, it's more a matter of managing some of the needs, and there is no such vision of rural healthcare being a problem that needs to be addressed also in the cross-border context. So I will gladly answer some questions if you have, and I thank you for the time.
Thanks a lot, Alban. Yes, you might have interaction in the chat and also later in the breakouts. Thank you for presenting these two different case studies and these push and pull factors across borders that, as you said, most of them are remote or rural. Now, last but not least, I'm going to welcome what is just the very last keynote speaker of today before we move into the discussion, and is Dr. Miriam Dolan. We are going to now speak about something slightly different. There are many factors, many issues around enhancing health access. We can perhaps not speak about all of them in today's webinar because time is a constraint. But Miriam, you are going to give us a nuance of a different perspective, which is the social farming and the social prescribing, and how to connect patients with community-based resources to improve overall well-being. So Miriam, welcome, and please, the floor is yours. We see already your presentation up.
Excellent, you can see it all now. Thanks, Patricia, and yeah, very interesting presentations until now. Alban, I actually work as a very busy but very proud rural GP in Northern Ireland. So I actually work in a border area too. So I will keep it short because I'm really looking forward to go into the breakout rooms and start to discuss those issues. So yeah, I'm a GP in Northern Ireland, and but I'm also a social farmer and a farmer. And my husband is actually also on the call. Malaki, he is the co-chair of the social farms and gardens. I'm also a member of URIPA and a member of the Social Prescribing and Community Orientation Special Interest Group, and that is an Wonka Europe interest group just formed. So yeah, a little bit about social prescribing, but mainly about utilizing our biggest rural community asset, and that is agriculture, I think. So that's the case I'm going to make, but I'm going to really talk about our local experience on our farm, which is called Dolan Social Farm. So first, a little bit about social prescribing. It has been mentioned, I think somebody mentioned men's shed, so that's an example of social prescribing. So social prescribing is really a bit away from the biomedical model and looking at health in its broadest form, in its broadest WHO definition, really, isn't it? It's also about social health and about mental health and physical health, but also, you know, connecting people and about, we go a wee bit over that definition. So social prescribing is a means of connecting people a bit to a range of non-clinical initiatives in their community. And that, of course, can improve health, well-being. And there's more and more research coming out that really works. For people, it is a term people get better to activation, social mobilization. And by doing that, you actually address some social determinants of health. And that can be at so many different levels. It can also be so many different activities. And those activities are often coordinated then by our local community groups, but it can also be public health projects, EU-funded projects, and at times also primary care organizations. So let's go back to the farm. So those pictures are from our farm. So in 2013, we got involved in an EU-funded project on social farming, and we're still at it. So that's 10 years later. So we are a normal farm, a commercial farm. So we have sheep and we have cows, and almost every day of the week, people come to our farm to just work alongside us, mainly alongside Maliki. And so there are people with identified needs, and we do have that direct link with statutory services. And often as a rural GP, I think, well, why don't we have more of those farms? Why are there not more farms in my community that I can actually refer to? And it doesn't have to be people with really kind of enduring mental health issues like the people that come to our farm, but it can be people with low levels mental health issues, anxiety related issues. And by coming to the farm, it of course can help their social and also their mental health. I can of course say that this is a good kind of way of looking at health, but there is more and more research. This is an independent research done on our farm, done by Queen's University in Belfast, and this is the few quotes of the people that come to our farm. And the striking thing is actually the people that do come to our farm are most of the time actually from a rural background. So it is really not the activities, it's actually more that social interaction that really helps people. And so that you do your job, you feed the animals, and then you go have your cup of tea. And it's about reconnecting people to your communities. I got a few statistics also from, I have to mention her name, Marian Elling. So she's from Wageningen University in the Netherlands. And actually that is the University of Agriculture. So it's a very intersectoral kind of approach to help. And more about the numbers of social farms currently in the EU. Like in the Netherlands, we would have 1,250 social farms in 2020. In Flanders, in Belgium, there are 1,000. Italy has 3,000 social farms. Austria has 700. Ireland has around 195. And the UK has around 3,000. And then I think, well, how many family farms are there actually in Europe? And this is a statistic of Eurostat. And it's very much also about that family farm, isn't it? And when you look at this statistic, there's so many family farms because it's about connecting people into those families and back into their communities. So potential is great, very, very, large, and it really needs more investment, really. This is definition just about social agriculture. It's the definition of the European Economic and Social Committee in 2012. So it is a kind of a multi-functional view of agriculture that combines farming with social and healthcare services at a very local level. So farms become places where people with particular needs can take part in daily farming routines as a way of furthering development, making progress and improving their health and well-being. So in summary, social agriculture has a lot of benefits. I spoke about the social and the health benefits, but of course, often those social farms become actually social hubs. So there's definitely a rural community development aspect to it. It also can lead to a more sustainable agriculture in local areas because young farmers, or not, you don't have young, but farmers can see this as an extra income, and it makes the farm more sustainable as some kind of a diversification. So health, social, economic, and let's not forget the environmental added value too, because less intense agriculture, of course, helps too when you have a different. There's another stream of income into the farm. Now, a few links about good cases, and also the EU has developed kind of learning tools for social farmers and people that come to the farm. And this is just a link to our website, Go and Social Farm, and my email address. So I try to go as quick as possible, Tricia.
Yes, Miriam, thanks a lot. That very super clear, super straightforward, great potential there. As you said, it's not only about the health, but it's also about the rural development. We've been speaking about how investing in the health, it's also have like a positive impact in other rural development aspects. It's not only about health. It's really a comprehensive impact and positive benefits for the rural community.